Yes, very importantly in Tetralogy of Fallot, very importantly, we spoke about right ventricular hypertrophy. We spoke about right ventricular outflow tract obstruction, which is known as pulmonary stenosis. We have a ventricular septal defect, which we know it is a right to left shunt from the beginning. That is why reversal of shunt is not possible in this congenital heart disease. And one more thing I spoke about it that this VSD is a very large VSD. It's a very large VSD. बहुत बड़ा. That is why whatever the blood is coming from right atrium to right ventricle, straight away it goes to the left ventricle. So that is why also we spoke about one thing that right ventricular hypertrophy over here. It is not because of what you call VSD. It is because of the overriding of aorta. This RVH is because of the overriding of aorta. That overriding actually is having a back pressure, basically causing right ventricular hypertrophy. Now, coming to the heart sounds, very easy, very simple. We have the first heart sound, which is because of the closure of tricuspid and mitral valve. And we have the second heart sound, which is because of the closure of the pulmonary and aortic valves. S1, it is because of T1 and M1. And S2, it is because of P2 and A2. Okay. Now we all know in the tetralogy of Fallot, the first heart sound remains the normal. The first heart sound because there is no problem to the T1 and M1. T1 and M1 are perfectly fine only. T1 and M1 are perfectly fine only. Whereas the second heart sound, it is because of the closure of P2 and A2. The second heart sound, it is because of the closure of the P2 and A2. And as the in simple, I'll talk about very simple words. Okay, we all know the patient will have a pulmonary stenosis, yes or no? So naturally, if there is a pulmonary stenosis, there is no sound at the pulmonary at a valve. There'll be just a single second heart sound. Only A2 will be heard, and that's it. And single audible A2 is quite loud. The single audible A2, it's quite loud because the aorta is anteriorly displaced. I told you like this overriding of aorta, yes or no? So overriding of aorta, that means the aorta is anteriorly displaced, and that is kind of producing a sound, and that is a single, only A2 is heard. The single audible A2 is quite loud. P2, I can say simple words is inaudible because there is a right ventricular outflow tract obstruction. P2 is closed. So P2 either you can say soft or inaudible. Basically, inaudible is something I will always remember. We have spoken about it. Can a tetralogy of fallow patient can land up into failure? The answer is no. The patient cannot have cannot have a failure problem because of the large VSD. Remember that, number one. Number two, then there are some very exceptions there. This is the exam question now, like this is a very little hi-fi question. So can a tetralogy of fallow patient land up into failure? Normally it can't land up into failure, but very importantly, remember one very important point: the VSD of the TOF, the VSD component of the TOF is always large enough to allow free exit from the right to left, from the right to the left, to have the free flow exit. That is the whole story, you know. And that is why the blood from the right ventricle can go to the left ventricle very easily. That is why there is no failure. There is no failure. But exceptions are there, and the mnemonic of that exception is RISA. RISA is the mnemonic for the exceptions where you might see, features of failure. So RISA, A for anemia. Naturally, if the patient has a severe anemia, that baby can, TOF patient can land up into failure. R for right ventricular dysfunction. Right ventricular dysfunction. So right ventricular dysfunction due to prolonged hypoxia. Right ventricular dysfunction due to long-standing hypoxia. This is a DNB and exam questions, that what are the, what you call the exceptions where the baby can land up into failure. I'll repeat again in simple one-liner: tetralogy of Fallot patient don't land up into failure because of large VSD. But the exceptions are the mnemonic is RISA, R for right ventricular dysfunction due to long-standing severe hypoxia, A for, you can say, aortic regurgitation. If the patient has aortic regurgitation, then naturally, then the baby can land up into failure. If aorta is getting issued, then yes. So aortic regurgitation, I for infective endocarditis, and S for systemic hypertension, systemic hypertension. I'll repeat again. You tell yourself you're reading this for the first and last time in your entire life. Simple words. The causes for tetralogy of Fallot patient going into failure, the mnemonic is RISA. R for right ventricular dysfunction due to long-standing hypoxia. A for aortic regurg. I for infective endocarditis. S for systemic hypertension. And A for anemia. Anemia, remember that. Acha, can ASD patient go into failure? This is something we have spoken about it. Remember, if I say PDA, which is between the pulmonary artery and descending aorta, definitely PDA can land up into failure. Even VSD also, baby can land up into reversal of shunt or failure. ASD, like some books have written, it's not possible, but Park Cardiology have written, rarely it might. Rarely ASD can land up into failure. For ASD to land up into failure, that means I need a pulmonary artery hypertension. I need a right ventricular hypertrophy, right atrial hypertrophy, and then the reversal of the ASD will happen, or then the failure features will happen. Are you understanding? So, simple words, itni dur, so far, ASD and pulmonary artery are very, very far. So, in cut short, failure can be seen in PDA, followed by VSD, but very less likely in a case of ASD. Some book have written rarely it can happen, so fine, it can happen. That's it. Now, boot-shaped heart. I remember boot-shaped heart. This, we all know tetralogy of Fallot has a boot-shaped heart. Why this boot shape is there? Why? Pulmonary artery. Who is responsible? So, because of the hypoplastic, we have done that because of the hypoplastic main pulmonary artery. We all know that tetralogy of Fallot has a pulmonary stenosis. So, when pulmonary stenosis is there because of this hypoplastic pulmonary artery, that is giving a boot shape. Remember, boot shape, the in French we say coeur en sabot. It is because of the absence of the main pulmonary artery segment that give the shape of the boot shape. What is the causes of right ventricular hypertrophy in tetralogy of Fallot? This also simple. I told you what is the cause of, see, cardio is like maths, okay? Very simple. What is the cause of right ventricular hypertrophy in a case of tetralogy of Fallot? Lot of students think that VSD is the cause for RVH, but I told you VSD is very, very large. We have a very large VSD. So VSD is not a cause of tetralogy of Fallot. It is the overriding of aorta, which is having the cause for, which is the cause for right ventricular hypertrophy. Overriding of aorta, in simple words, I can say, if I say in very simple words, you should know this is the four chamber structure of the heart, and this is the VSD. So blood is coming from right atrium to right ventricle, right? From the right ventricle, the blood is going to the left ventricle. Now, from the left ventricle, when the blood goes to the aorta, there is a overriding of aorta. Aorta is little anteriorly displaced, or in simple words, there is kind of a little, the window, the students who are going to the aorta or through the aorta, they are having little problem, little, like normally 10 students can go down, here only 5 students can go down. When 5 students can go down, slowly all the students are waiting from behind, waiting from behind, and that is causing right ventricular hypertrophy. पाइप छोटी है ना, पीछे पानी प्रेशर बढ़ जाएगा. The pipe, the students only 5 can go down na. So from the back end, the students are waiting, and more students are, waiting behind. So that is why the whole story we're gonna have here, that is right ventricular hypertrophy you see in tetralogy of Fallot. Okay, next question. What are the clinical features of Tetralogy of Fallot. Clinical feature, one of the most important parts. Naturally, can I say the patient will have cyanosis? Yes or no? What do you think? Yeah, Tetralogy of Fallot has a pulmonary stenosis. So yes, the baby can have cyanosis. That's very well put. Yes, the baby can have cyanosis. The most commonest symptom, very importantly, the patient will have dyspnea on exertion and exercise intolerance, because naturally I am having a hypoxic condition. I am having a pulmonary stenosis. My lungs are not available for purification because the channel, the pulmonary artery, is totally blocked. There is a pulmonary stenosis, and that is why I'm going to have dyspnea and exercise intolerance. So the commonest symptom according to Park Cardiology is dyspnea on exertion and exercise intolerance. And very, very important one point, that is the patient feels very comfortable in the squatting position. बच्चे को सांस चढ़ती है और जल्दी से वो स्क्वाटिंग में बैठ जाता है. The baby feels very dyspnea on exertion and breathlessness, and he assumes a position of squatting position. So in simple words, if I talk about this now, what is a cyanotic or TET spell? That's the important part over here. It's very simple, very easy. Remember, very importantly, we all know that there is a pulmonary artery and there is a pulmonary stenosis. We all know that. Yes, there is a, in Tetralogy of Fallot, there is a VSD and there is a pulmonary stenosis. Now what will happen? More the baby will cry, the more the baby will cry. If the baby gets, if a Tetralogy of Fallot baby cry, if a Tetralogy of Fallot baby cry, the more the baby will cry. There's one line that I want you to remember. There'll be infundibular spasm. There will be a infundibular spasm. Sir, what is infundibulum? In the last class, I told you one part of the pulmonary artery that is known as infundibulum. More the baby will cry, this part, this infundibular spasm will be happen. So more pulmonary artery spasm will be happen, the more right to left shunt of the VSD will happen. The more right to left shunt VSD will happen. So I'll repeat again, the crying causes infundibular spasm, and more shunting of the blood will happen, and that is how the baby is gonna have cyanosis, known as a cyanotic spell. So that is the main background of cyanotic spell or TET spell you see in a case of baby. जितना ज्यादा बच्चा रोएगा उतना नीला और उतना परेशान हो जाएगा. The more the baby will cry, he's gonna have infundibular spasm that leads to VSD, more shunting of the blood, and naturally that causes cyanosis. So simple words, if I talk about, number one, the baby will cry. After crying, he'll be dyspneic. So crying, suddenly he'll feel dyspnea more. And after dyspnea, obviously, because of the pulmonary stenosis or infundibular spasm, there is a cyanosis. And cyanosis, naturally, suddenly the baby will have a loss of consciousness and he can throw a seizure. So this is very important. Crying, followed by dyspnea, cyanosis, LOC, and convulsions. So I told you, when the baby cry, there is an infundibular spasm. There will be, I'm revising now. Baby when cry, there will be infundibular spasm. I told you, this is the pulmonary artery. And this part, this infundibular spasm, which is also infundibulum, it is also known as conus arteriosus, and this part here is the infundibulum, and there'll be spasm over here, like that. And that is how suddenly the shunting of the blood will happen, and that's the whole story. So this part is done. Now the answer, very important, is what is the treatment? Why squatting? Basically, the treatment for this is squatting. The treatment for cyanotic spell, there is a hypoxia condition, cyanosis, hypoxia, VSD, shunting. So number one, you give oxygen, and number two, put the patient in the knee chest position. In your theory paper also, if someone asks you Tetralogy of Fallot or cyanotic spell treatment, first thing is oxygen, because it is a cyanotic congenital heart, no, pulmonary stenosis, no, lungs are not available, no. So naturally, oxygen is the first thing, and then the baby will have a kind of a knee chest position or squatting position. The baby will feel better. Okay. Now, why the baby is feeling better in this knee chest position? Because knee chest position is a very important point. Okay. Yeah. Now knee chest position, imagine this knee chest position, what it will go, it will cause decrease in the venous return of the heart. If I sit in the knee chest position, the blood from the lower limbs, less blood will go to the upper limbs. I'll repeat again. If I am in the knee chest position, then blood from the lower limbs, less blood will go to the upper limb. When less blood will go to the upper limb, the less blood will enter the superior vena cava, the less blood will go to the right ventricle, and the less shunting will happen, and less infundibular spasm will happen. So less infundibular spasm and less shunting of the blood. So less infundibular spasm and less shunting. So this is something very important for the exam purpose, that what is the pathophysiology for the squatting. So squatting basically reduces the venous return to the heart. बच्चा नीचे बैठेगा तो खून ऊपर जो है कम जाएगा, decrease venous return to the heart होगा. And that's it. So decrease venous return to the heart means decrease right to left shunting, decrease in fundibular spasm and all that. That is one thing, number one. This is one benefit of the squatting or the knee chest position. The second benefit of the knee chest position will be that there will be an increase in the systemic vascular resistance. What is the systemic vascular resistance? Which is the systemic vessel? Aorta. Now, aorta is the systemic vessel. See, one thing will be decrease blood from the lower limbs will go to the upper limbs, and from the upper limbs to the right side of the heart. That is one pathology, one pathophysiology. The second is even the aortic resistance, aorta भी allow थोड़ा कम करेगा blood को इस तरफ. There will be increase in the systemic vascular resistance. The systemic vessel, the aorta, that will show some resistance over here. And so again, the less blood will go through the VSD, and less shunting means less hypoxia or less cyanosis will happen. So in simple one-liner, decrease, so squatting causes decreased venous return to the heart. And second, there is an increase in the systemic vascular resistance. That is systemic vascular resistance increasing itself also causing the decrease in the right to left shunt through the VSD. That's what it's written, no? Decreased blood shunting across the VSD. Done. So yeah, that's it. That finishes this part. And what is the treatment now? Acha, when does clubbing occurs in tetralogy of Fallot? That's a very nice question. So clubbing, we all know na, tetralogy of Fallot, it has a pulmonary stenosis. When tetralogy of Fallot has a pulmonary stenosis, means the cyanosis problem we're talking about. Whenever there is a cyanosis or nothing but hypoxia, cyanosis or hypoxia, basically it causes end artery dilatation. It causes end artery dilatation, and this end artery dilatation that leads to clubbing. Whenever I have a cyanosis causes end artery. These fingers are my fingers, my lower limb, my toes are my end arteries. Cyanosis or hypoxia causes end artery dilatation as a compensatory mechanism, and that leads to clubbing. And that you see around 1 year of life, long standing hypoxia, slowly that leads to clubbing. Now treatment of cyanotic spell, I told you, very important. First is oxygen. First is knee chest position and oxygen. These are like our mainstay of treatment. If you are giving exam, this is something like oxygen and knee chest position is something must over here. Now I told you cyanosis, the baby can have a loss of consciousness, the baby can throw a seizure also. So those things also you have to take care of it. Number one, for that, for seizure and everything, and the baby going into so much of hypoxia, MCQ exam question, you can give IV or subcutaneous morphine. You can give IV or subcutaneous morphine at the rate of 0.1 mg per kg. So IV subcutaneous morphine you can give at the rate of 0.1 mg per kg. Basically, that decreases the respiratory center. This depresses the respiratory center. The baby is having dyspnea on exertion and stuff like that. So we have to relax him basically. So remember, number one, oxygen. Number two, knee chest position. Number three, IV or subcutaneous morphine, because that depresses the respiratory respiratory center. Oxygen will definitely remove the hypoxia. Knee chest position, I told you, decrease venous return to the heart. So every three important treatments, and there are three important reasoning why it is happening. Oxygen, knee chest, at least the take home message for today will be oxygen, knee chest position, or IV or subcutaneous morphine at the rate of 0.1 mg per kg. And naturally, the patient's cyanosis or the patient is having a seizure, that time he can show you metabolic acidosis. The baby can show you metabolic acidosis because he's going to have loss of consciousness. So he can have a low pH can happen. So to neutralize the acidosis, then definitely soda bicarb we can give over here. So that's a fourth treatment. Number one, oxygen. Number two, knee chest position. Number three, IV morphine or subcutaneous morphine. It depresses the respiratory center. And number four is soda bicarb if the patient has acidosis. And if this, and I told you the baby, the TOF patient, it can go to failure if he has anemia. That also you have to keep in mind. If you have the patient has anemia, then you give blood transfusion. If the patient has anemia, you give blood transfusion. So knee chest position, oxygen, morphine, soda bicarb, that is done. And also some role is there very importantly of the beta blocker, that is propranolol. So beta blocker. So you know beta 1 is in heart, it causes tachycardia. So beta blocker basically it causes the vasoconstriction. So beta 1 propranolol we can give over here. 0.1 mg you're giving the morphine and 0.5 mg you're giving the propranolol, that you should know. And I told you if the patient has anemia, very importantly, PRBC you give if the patient is hemoglobin less than 12. Normally, sick patient, HP less than 10, we give blood. What is PRBC? Packed red blood cell. Okay, I'll repeat again. If the patient is hemoglobin is less than 10 in general, normally sick patients and all, HB less than 10 and the patient is sick, then definitely PRBC you will give, packed red blood cell. But tetralogy of Fallot patient, HP less than 12, sick or not sick, you give it. Okay, HP less than 10 and TOF patient, and coming to the TET spell, you give the what you call the PRBC, that is